Good morning and evening, wherever you are in the world, and welcome to the Bonnie J. Addario Lung Cancer Living Room and Patient Educational Series. I'm Bonnie, and thank you for joining us. From our living room to yours. We are all living with lung cancer, and our goal is to bring hope into your home. Empowered patients live longer, and our message is simple. We want you to live.
I want to just thank everybody who's joining us tonight. I know it's a little crazy with the holidays, just winding up, just gearing up and starting to start. So thank you guys from the bottom of my heart. I know my sister and my mom wish that they could be here tonight. They've actually passed the torch over to me. But I know most of you guys from the events that we have and from being here every month. So thanks again for coming. It's great to see you guys. You know, we're so excited to have this support group, this living room every month, and I want to thank everybody who's logged on online, because there are many people who log online from around the world, so to say. They're, you know, traveling across the country, there's not many support groups specific for lung cancer, and so we're so happy to be able to offer this to them. So, and they'll be chiming in, asking questions for Dr. Krishna and anybody else here. I spoke to Danielle. She gave me strict instructions to say that she wishes that she could be here tonight. Danielle is now flying to New York. She just left Boston. She was doing some wonderful things. She was on a panel of speakers with, oh my goodness, I can't remember. Foundation Medicine. I'm sorry, Foundation Medicine based out of Boston, specific to what she does with patients. A big round of applause for her. So we're excited for her. And she's now going to fly and meet my mom, who is with Faster Cures. Faster Cures is Michael Milken's organization. And of course, Bonnie J. Addario Lung Cancer Foundation is part of the TRAIN group. So they're doing some wonderful things on the East Coast. So. But they wish they could be here, and they send their love to you guys. But Danielle did say that she wanted to have the roundtable first. Everybody kind of go through and give us updates and introduce yourselves and kind of what we usually do. And then after that, we're going to have Dr. Krishna speak and do a wonderful presentation on what he does. That's it. Dave, do you want to start?
Well, I guess I'm Dave Palomares. I guess it was about almost 4 years ago. I thought I had a pulled muscle in my right side, and I used to go to the gym quite a bit, so I thought it was just another pulled muscle, and it never went away. And so I decided to go see a doctor, and she agreed. She thought it was a pulled muscle, but just to be safe, she ordered an X-ray, and that's when they found some fluid in my right pleural cavity. So that was in, let's see, January of 2009. I was diagnosed with mesothelioma, and I went to UCSF and saw Terry Jahan. He put together a treatment protocol, and in March 2009, I had what is called an extrapleural pneumonectomy, which is basically I had my right lung removed. And then I went through chemotherapy, radiation therapy, and all my treatments pretty much were over by October of 2009. And since then, I've had periodic CT scans to monitor my condition. And up until August, everything is negative. So things are looking good. Thanks.
Great, Dave. And just a reminder for our online viewers, we are going around in the room here at our home office in San Carlos and introducing and telling our own stories. We know that our own personal stories make a difference because it may just be that same fingerprint that someone else has seen. or been through. So it's real important. So if our online viewers wish to share their stories as well online, we have Jennifer Hughes over in the corner who will make sure that Andrea and I get your stories so that we can share them at the end of this as well. Because it's real important for everyone to know where you've been, what's happened, some of the things you're doing, because I think it all matters to each other to know that there are stories out there that may be similar to yours. So thanks, Dave.
Sure. My name is Bill Morris. I'm here with my wife, Christy, and to give her as much support as I possibly can.
And I'm Christy Morris, and also joining us for the first time is daughter Jay Morris, so I feel duly supported here. And I was diagnosed with stage 4 lung cancer almost 4 years, or 3 years ago. I'm wishing 4 years. 3 years ago in December. And I've been through a whole series of treatments and all of the tissue testing to see if I have all those little gene mutations, which I don't. So currently I am on a chemotherapy treatment, very low dose, Taxotere, and also Iridia, because the cancer is in my bones. And it's working. And my last PET scan was in September, and since November, since a year ago this month, my PET scans have been getting progressively better. The areas of cancer are less hot, no new cancer has developed, and so I'm very grateful for the treatment, and as long as my body is tolerating it, of course I'm losing my hair for the second time, but that's just the way it is. And as long as my body is holding up with this treatment and my body is responding, I'll be on this for a while. And so pretty soon I'll be able to say 4 years ago, but it was 3 years ago in December. Thank you.
Hi, I'm Jay Morris. I'm her daughter, and I'm here to support her. And my first time coming, I'm very excited.
I'm Penelope. I'm here for my mom. She was diagnosed in February, stage 4. She went on Tarceva, and after about 6 months, it kind of stopped working. Things progressed. So she just started last month some IV chemo. She's doing carboplatin, Ellipta, and Avastin once every 3 weeks. So she had a second round of it yesterday. She seems to tolerate it pretty well. She's in great spirits. She was with me and the kids this morning, and then they went home today. So she got to play with all her grandkids, and she seems to be doing well. They've been monitoring her CEA blood level, and I don't know that that's all that common to do, but hers has been pretty consistent with the scan results that she's been getting. So hers had went up, and that's when we did see progression in her scan as well. Started the IV chemo, and just yesterday they told us her levels went down again. So they're very optimistic that this chemo will really help her, and hopefully we can do some target radiation if we can get things to shrink a little bit. So she feels good, and then her and I and 2 of her grandkids got to do the barrel race that the Lung Cancer Foundation had a benefit for up in Santa Rosa. So we did that at the beginning of the month. My mom hasn't been on her horse in 2 years, and she got to ride, and she loved it. So we had a great time.
Check out our Facebook page. They're there. Penelope and Christine. Do we need to pass? There we go. Thanks.
I'm Jim Duran, and I'm here to support Nita, who is right in the row behind me, and want to give you all a shout out to my daughter Laurie, who's watching from San Juan Capistrano. So keep on streaming, and really appreciate what you all do, and had a great time at the gala. So good to be here.
I'm Ray, and I'm here with my my wife Mary, who's been going through this, and I'm here to support her. And I really want to thank this great foundation. It's just been so helpful to come here and listen to other people. It's been helpful to keep up on sort of what's going on in the practice and sort of the state of the art. And it's just, it just helps so much to know about other people in the same boat that you were in. So thank you for that.
I'll second that. I'm very grateful to be here. And my name's Mary, and I was diagnosed with stage 4 non-small cell adenocarcinoma in October of 2010. My mother passed away from lung cancer at 63, and my sister, just this week, passed away from lung cancer. But I was kind of aware of it when I turned 61. I thought I started getting this really bad cough, and my doctor said it was acid reflux. And after about 3 years, I was getting regular chest X-rays, but I wanted a CAT scan, and that wasn't the screening then, you know. I think it might be now, but so I wasn't able to get one. And then I did get pneumonia in July of 2010, and it masked, I guess it was covering up the lung cancer. But when I went into my physical in October of 2010, I said, I'm just coughing so much, and you know, I don't know what is going on. So I had another chest X-ray and then had the CAT scan. A CAT scan is really, I think, the best. And, you know, if in your gut you feel like something's really wrong, I think you should just really fight to get what you need. Anyway, I had 13 rounds of carboplatin, Alimta, and Avastin, and it really killed the cancer. I mean, like, I had it in my spine, and I haven't seen anything light up in my spine since the very first time, which I'm so happy about. And someone to say about that? Oh, it killed the cancer, but it also hurt my kidneys. And I got very sick a year ago, but I made it through, and my kidneys are recovering. And I had target radiation in November of 2011. And actually, Dr. Krishna did he put the markers. He was so good. And then afterwards, I didn't have any kind of treatment until just 6 weeks ago. I started on Tarceva because a new tumor came next to the old tumor. And I have the EGFR gene mutation, which allows me to take the Tarceva, and I'm on that right now. And I feel great. I mean, I really feel good. And I have continued exercising an hour every day, except for that period when I was in the hospital and for about a month afterwards. But it really keeps my spirits up, and I think it keeps me healthy. And that's it.
Woohoo.
Hi, my name is Rick. I'm here to support my wife, Tina, who's sitting to my right. All I'd like to say is that the foundation has done great things. Recently, we participated in the walk in Golden Gate Park, or run. I walked, which was fantastic, beautiful day. And the gala was just unbelievable. It was just so much fun, and what a great thing. And you guys did a great job.
I don't think you ever left the dance floor. Right? Didn't we have to drag them off? I mean, wasn't it like, okay, that was the last dance? Come on. It was so fun.
It was. My name's Tina, and I was diagnosed 2 years ago, last week. And I went through chemo and radiation, and my scans so far have been no evidence of active disease as of this last October. I had a PET scan and it was clean, so that's really good. But I got a little surprise last week. I went to my regular dermatologist just for a little skin check to, burn off those little carbuncles. Barnacles?
Yeah.
That. Barnacles. And he goes, "What's this?" And he sees the tiniest little freckle on my arm. I don't like it. I'm doing a biopsy. It's melanoma. So I'm having some little surgical procedure on Thursday. And they're going to do a lymph node biopsy, and I don't know. But you just got to do what you got to do, you know?
Well, let us know.
Yes.
I'm Esty Caldwell, and I was diagnosed in 2003. And I had bronchoalveolar stage 1, and I had surgery, and they've been monitoring it since then. The only reason I went for an X-ray is because my daughter died of lung cancer, and they found it out in stage 4 because they treated her for colds and flus, and they said, you have allergies. Till she was in stage 4, she lived in Golden, Colorado, and they just didn't do anything about it. By the time they gave her an X-ray, she was in stage 4, and she died, about 8 years ago. Actually, at the time, I had lung cancer the same time she was dying of lung cancer. So it was all at the same time. So I go for CT scans, and they seem to be okay. And I have many spots, but they haven't changed, so I'm happy.
They're watching you. And we're going to talk about the next edition of the Lung Times, but Esty and her Phil are rock stars in it, so you have to check it out after. But we should make sure that everyone in the back row has an opportunity to introduce themselves if they care to. Come on up, grab a mic. And then I'm going to, and we've got a couple new folks, and then I'm going to make sure that I remind Jen if there's anybody online that wants to be introduced. And I also got one of the voices in my head said I didn't introduce myself either, so I'll do that at the end. When everybody in the back row, anybody?
Brian, you're not talking today?
We're forcing people to come up and be identified. The post office doesn't have your picture, do they? That's not what you're worried about? No.
We should acknowledge and thank Evie, who was a wonder in getting our Lung Times out in our newsletter. It was, she was a miracle in editing and proofing and making sure the content was perfect. So thank you very much.
The last time she probably says to us in passing, I'm happy to volunteer. Should you need, now we've got her as a full-time volunteer.
Yeah.
Yes, I had the most wonderful experience of working on the newsletter with the
Sheila,
staff,
yeah.
and particularly with Sheila, who isn't here this evening. But as we all know, the staff here is very, very, very special. And what I would say about the newsletter is I hope you'll all read it. I hope you give it out to all your friends. The stories are inspirational. And although I wasn't able to be at the big gala, I was able to be at a luncheon at El Camino Hospital about 2 weeks ago, at which Bonnie spoke. And once again, the inspiration and the heart and the hope that this organization gives is really wonderful. So thank you, and I had a blast volunteering. I really did. So.
And the luncheon was at the Palo Alto Medical Foundation in Mountain View. Mm-hmm.
Right. So thank you.
Thanks, Evie. Okay, Jen, do we have anybody online that wishes to be introduced? Nope, we're good. Okay.
No.
And we have one more. Hello, how are you?
Hi, everyone. My name is Elaine Gray, and I have stage 4 lung cancer and was diagnosed in May of 2008. And I'm tired of it, I'll tell you that. I have just lost my hair for the 3rd time, and each time was totally different. This one under the wig, this is my Marilyn Monroe wig, by the way, and I love it, and I'm wearing hats and scarves, and I still have hair, but I'm going to have my son shave it for me this Saturday when he comes. I don't, I just have the pinkest scarf, the pinkest scalp, and when I don't have my wig on or something, it just looks terrible. But I just had a question, if anyone else, I have just the most terrible case of, what did I tell you it was?
Ulcer.
Pardon?
An ulcer?
No, my disease on my tongue and an ulcer.
A fungus.
And it's a fungus. According to my dentist and 3 other doctors, didn't know what it was. But there's an ulcer about the size of a quarter, which has shrunk some. But my tongue is burning 24 hours, 7 days a week. It's so painful, I can hardly eat. And I've had rinses and pastes. I've spent so much money and nothing has worked. But, a pain pill here and there, that'll do it for temporarily anyway. But I just don't, I'm doing a CT scan and a bone scan on Friday. Dr. Dormady, my love. And I hope that he's not going to continue. I'm taking, not Tarceva, I already did Tarceva. I'm taking Avastin and Taxotere. It's the 2 of them. And the tongue problem is from the chemo. And I have had these sores for like 15 weeks. It's just miserable. And I hardly ate Thanksgiving dinner. I fed my turkey to the dogs. They were under the table, 4 of them. So they had a good Thanksgiving. But anyway, I'm in good spirits. I'm anxious to see the CT scan because this is with the new medication that I've been taking ever since I went to Dr. Dormady. So I'm hoping that it will show something good. And I think it will. It has so far for 4.5 years, so I'm hoping that it still will. So I feel very grateful. I moved to Redwood City to be close to my sons. One's in San Francisco and one is in Castro Valley. And it is wonderful to have family close. But I got to tell you, it was pretty wonderful to live in Carmel for 46 years. Anyway, that was my Carmel days. Now it's family days, and I'm very happy. My sons are wonderful. So thank you all very much, and I'm happy to be here tonight. She's going to
Miss Sally's going to pass.
So I'm going to add real quick that when my mom was going through treatment, my mom's Bonnie, so when she was going through treatment, she had a lot of the sores. So I'll reach out to her and see. I don't remember because it was 8 years ago, 9 years ago. So I'll ask her for you because it was tough on her. Yeah. 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 Oh, Danielle's online. Hi, Danielle.
So Danielle is online. Hi, Danielle. I'm not quite sure how you do this, modern technology. She's on an airplane. Does the pilot know that you're logging in? Because you're supposed to shut down these things, right? There she is breaking the rules again, right? Ask Dr. Dormady, Elaine, about Novocaine rinse. Does that sound like something?
Well, you need to know what the answer is. You talk about a fungus, but it could also be a virus.
Oh, we've got to get you a microphone. Thank you. Sorry about that, Dr. Krishna. And we're going to introduce you formally, too.
Sure. So, I think it's important to find out what this is. It may or may not be a fungus. It could be a virus. It could be a herpes virus. So you may not be treated for that. You said that you were taking some lozenges. Is that Mycelex tortious? Okay, so,
Also,
I think it's important for you to see.
Also, I'm taking a lidocaine rinse, which
so
is
that's
probably the
Novocaine.
same thing.
So you're basically treating the symptoms, but what I think is we need to look at what this is and perhaps maybe do a smear or a biopsy on it. And, well, it's not a very painful
I've
thing.
had a biopsy a
You
couple
did.
of years ago. I'm susceptible to mouth sores, but nothing like this.
Well, so have you tried acyclovir?
Tried what?
Acyclovir? Like it's
Yeah.
against a herpes virus. So I think
Yeah.
have you seen an infectious disease doctor about this?
I've seen the oncologist, the emergency room doctor, because I fell and cut my hand.
Well, I suggest that you see an infectious disease doctor.
Is that the kind you would go to? I need to see somebody
Correct.
that can look at this and say,
Yeah,
this is what
but, ulcers in the mouth can be due to many reasons. It may or may not be related to, it could be an infection, it could be an inflammation.
Yeah.
So we need to kind of figure out what the causes. Most of the medications that you told me is geared towards treating the symptoms. We need to look at what the underlying cause is and then treat the underlying cause. I think that would provide you with more long-lasting remedy.
Okay, well, thank you very much. That one that you said.
I think one of the things that I would entertain is to look at, is
one
it
for the herpes virus. I suggested that to Dr. I said, what is this, a herpes or something like that? And he said, it's not a virus. But did you say an infectious disease doctor?
Mm-hmm. Correct.
Is that
so? Why did he say that it is not a virus? Did we do a smear or a culture on it?
No, he just looked at it.
Okay, I think we need to there are specific smears. For example, for herpes, it's a smear called Zank smear, TZANK. So you have to put it in a specific medium. So there are specific tests that you have to do to make a diagnosis. If you do a run-of-the-mill smear and send it for culture, you may not be able to diagnose these things. Yeah. So you have to have a clinical suspicion in order for you to do the appropriate test and make a specific diagnosis, which is the reason why I thought maybe seeing an infectious disease doctor is a good idea.
I'll look into that.
Well, and we'll make sure Danielle knows, because she probably has a wide range of referrals for you, too, that are in our neighborhood, right?
Good, yeah.
So are we done with sort of isn't this wonderful, though, that we have this opportunity to sort of share our own experiences and our stories, and we have the experts right here that's what I think I, sort of sitting in the background, am so impressed with this group, that, it takes a village to sort of kind of put the puzzle together, and that's how we make discoveries, is with each other and the information. So my ear told me, I'm Danny Gasparini. I joined the Bonnie J. Addario Lung Cancer Foundation team over a year ago, or just about a year ago. My distinct pleasure is to open and provide opportunities for people to support our Lung Cancer Foundation and the research and work that's happening. So some of you might say that I'm the fundraiser. I happen to say that I'm providing opportunity, great experiences for people to leave legacies and to ensure that work like this foundation continues, and that we find a cure. So that's kind of me, and then I have the distinct pleasure of introducing Dr. Krishna, unless you have, Andrea, any more?
No, I think, I'm going to kind of go on what Danny said in regards to how wonderful this room is. And, I have the pleasure of going across the country and going to some major institutions that don't offer this for lung cancer. And, when my mom was first diagnosed, the only person that she could talk to was a breast cancer survivor. And it's different. It's a different type of cancer. It's a different type of treatment. It's, so I'm just so excited that we can offer this to you guys. I'm excited that it's, live streaming, and I know Danielle's in the works of bringing this on the road, which is even more exciting, because talking to patients across the United States, and they're like, when are you going to come to us? We want to be able to touch and feel and have the same experience that all of you guys have. So this warms my heart, and I know my sister's heart and everybody's heart, to be able to offer this to you guys. And I don't need to tell you guys what I do, because I think everybody knows what I do. I run around ragged at all the events, but that's it.
And, we were so worried. I don't think Danielle and Bonnie warned everybody last time that they weren't going to be here, and we're so glad about that, because we thought we'd be considered the substitute teachers, where everyone ditched out of class before the end of class was, because they knew the substitute teachers were coming. So we thank all of you for being here and behaving and being so cordial to each other, because we kind of got the lecture from Bonnie that we'd sort of end up taking this thing down, and the two of us would, and everybody would be, oh my gosh, what's happening? And so thank you for being here and being so gracious. And we also had a comment online. Everyone online wants to give Mary their deepest sympathy for her sister. Reed and Jane say hello, and that's from Mary and Ray. So thank you for that, and again, all of us share our sympathies with you. So I think we're now going to get to why we're here, and that is to hear from Dr. Ganesh Krishna, who is an interventional pulmonologist. So, which I love that word, because it means that you get them early enough so that we don't have to end up in surgery, correct? You get everybody as early as we possibly can. Who's with Palo Alto Medical Foundation, and it's with Sutter Health. So I should say, and Andre would make sure that I did, Dr. Krishna, in all of his spare time, was the chair of our Saratoga run, which with Jay Shri broke all records for raising money and awareness, amount of people that participated. So thank you so very much for caring enough to come out and do this and encourage your friends and family and your community to come out and participate in that run, because it raises great money for this organization to then go out and do things like this. So thanks, Dr. Krishna, for being here.
Okay, good evening, and thank you for the introduction. I'm very happy to be here. The Bonnie Addario Foundation has done a phenomenal, phenomenal job about raising awareness for lung cancer and helping patients understand what's out there. And in my practice, I've made it like a routine to refer patients, have you checked out the Addario Foundation website, because it provides them with amazing resources and awareness of what is out there, not just in the United States, but throughout the world. So they are kind of a lookout for patients with lung cancer. So I think it's a great service that they're providing, and I'm really happy to be a small part of that. So I'm going to be talking to you about what my specialty is. I'm a pulmonologist and a lung doctor, and there are not that many lung doctors that are interested in lung cancer and early diagnosis, so I have that special interest. And we have a certain research projects geared towards making early diagnosis of lung cancer and looking at more the molecular profile of lung cancer, and we'll talk about that briefly. I was doing procedures all day today, and I just, I'm not showing up in my jammies thinking that this is a living room conference, so please bear with me for my attire here. So I just came straight from the procedure room. So what interventional pulmonology actually is not a particular procedure, it's a specialty by itself. And an interventional pulmonologist specializes in minimally invasive techniques in the chest for diagnosis, treatment, and palliation of various lung diseases with special interest in lung cancer. So I will be, a lot of this is medical talk, and so I'm trying to simplify this, and the best way to help you understand as to what is out there and what I do is by showing specific case examples of actual patients that I had treated over the years. I had special training for interventional pulmonology in Germany, and I did my fellowship at Stanford, and I was a faculty there for about 8 years. And during that time, I went over to Germany and had special training, and I initiated that at Stanford and then moved on to Palo Alto Medical Foundation in 2008. And my program operates out of El Camino Hospital. So that's basically where I practice. And we'll have this, as a conversation, as an informal talk. So feel free to interrupt me if you had any questions halfway through, and I'll be happy to answer any questions, and we can just continue this as a conversation. So just to get the disclosures out of the way, I do have concern agreement with these above-mentioned entities, but for this particular talk, I have no conflict of interest. So, what is the definition of interventional pulmonology? Like I said before, it is a specialty geared towards minimally invasive techniques without incisions, using natural orifices like the nose or mouth to get into the lung and do procedures that help provide early diagnosis, certain treatment therapeutic measures, as well as palliative options when the disease has progressed towards a non-curable state, but can be checked with various modalities, including mechanical treatments that I will show you some examples of, and chemical treatment, including chemotherapy and other things. So why is lung cancer a big problem? We know that lung cancer is a huge healthcare problem. The deaths due to lung cancer are more than the next 4 cancers combined. And early diagnosis of lung cancer has always been tricky. We have mammograms for diagnosing breast cancer early, pap smears to diagnose cervical cancer early, colonoscopies to look at colon polyps and see if they are they are cancerous, and removing them early. But the lung is still a more complex organ. The breathing tube that we have that starts in the trachea, the main breathing tube, has 17 to 25 generations of further divisions of airways before it gets to the small sacs or air sacs called alveolar sacs that exchange oxygen for carbon dioxide. So, and I have listed the size of various breathing tubes, the main trachea in an adult human being being 20 to 25 millimeters, and the mainstem bronchus about 12 to 16 millimeters, which exponentially becomes smaller and smaller. And the relationship between these breathing tubes in different human beings is not same. So everybody's breathing tube angulates and branches off in different directions in different units. So it becomes more complex to access the peripheral areas of the lung. So there was a need for a interventional program or interventional specialty and multiple techniques that would help get through these areas without actually damaging the lung, without causing major surgical procedures, without using major surgical procedures, and making diagnosis or providing treatment options. So the advent of computer technology and technological advances in recent times has really revolutionized the medical imaging and other technologies that are available. So some of those technologies have been used in medical device making, and therefore that actually helped promote a starting of such a specialty. And these are some of the examples which we will go through. So electromagnetic navigation is the system that's right there. It's an image-guided procedure that actually uses the computerized software with the CT scan to navigate through to the peripheral areas of the lung using a very small probe, and I'll show you some examples of that. And we have direct visualization by putting in probes with ultrasound technology and looking at lymph nodes that we can biopsy in different stations. I'll show you some examples of that as well. So we also have developed various catheters that can be flexed and maneuvered through the various parts of the lung and can make biopsies or treat lung cancers, use laser. So there's catheter-based technology has made tremendous advances in the past 10, 15 years. And that also had initiated various devices that actually can help in the diagnosis, treatment, and management. So these are some of the non-cancer lung diseases can also be treated this way, like COPD, it would provide lung volume reduction. Some of these technologies we are actually looking to see, it's like bronchial thermoplasty, which uses radio frequency waves to debulk the smooth muscles that are underneath the breathing surfaces that makes the asthma patients' airways constrict more vigorously. But then, it also promote certain other ideas as to can we use the radio frequency technology to use it as a catheter to go into the deeper areas of the lung and treat lung cancer. So this also promotes like cross research possibilities as availability of one technology, can that be applied to a different disease? So it is, again, there are people like me who are constantly thinking about what we can do differently and more, in a minimally invasive fashion that can assist in early diagnosis or treatment of lung cancer, which is the ultimate goal. So at Palo Alto Medical Foundation, we have one of the largest interventional pulmonary programs in the world, and definitely in the Western United States. We offer about 22 to 24 different minimally invasive techniques. There are really no big comparable programs compared to us, and we are very proud that we have that program here as a part of the multidisciplinary cancer care. And this is something that again and again I would like to reinforce, and the Addario Foundation also does the same thing. Cancer treatment is not a one-man show. It is a multidisciplinary team care. And this multidisciplinary, one of the big goals that we all have is to have that multidisciplinary approach and not have various doctors treat various patients in islands. This is a team approach. Any patient with lung cancer has to be seen by this team, not this one doctor. It has to be a multidisciplinary approach involving all these specialties, and interventional pulmonology, in my opinion, is an integral part of such a multidisciplinary team. So we are proud to offer this very complete, comprehensive team, and we hope that that uniformity of care extends across the whole country and the whole world. So let me talk to you a little bit about each of these procedures. Clearly, there wasn't enough time to talk about every single procedure that I had listed the previous slide, but I'll highlight some of that with specific emphasis on lung cancer. So the electromagnetic navigation, like I said, is similar to a GPS system, which helps our automobile go from point A to point B. So this actually helps us to go from one point to another inside the lung using a probe, and I'll tell you how that works. So how is this comparable to the GPS system? So all of you are familiar with the GPS system that we use in the car. So if you think that the board that is underneath the patient is the earth, the tracheobronchial tree is the road, and there's 3 sensors that is placed on the chest as satellites, and the probe that I pass through the tracheobronchial tree as a car, this is comparable to a GPS. So the sensors recognize the probe, the electromagnetic field that is created by the board creates a sensing volume around the patient's chest, and within that sensing volume, that probe is recognized by the computer in multiple axes, and the feedback is given to the computer in about 170 times a second, so you know the real-time localization of that probe inside someone's chest. And combine that with the steering that we have, or a telescope that we have, that we can adjust and twist and turn this and drive this probe in a direction that we want, it becomes a navigation steerable complete system. So the components of the system include, if you have a CT scan, so we take that CT scan on a CD and we feed it into a specialized software and reconstruct that into a 3-dimensional view. And when the patient is actually lying on the electromagnetic board, as you see in the right-hand side of the slide, that sensing volume that is created around the patient, and the operator inserts the bronchoscope through the patient's mouth, through the endotracheal tube, because it's done under anesthesia, and we are able to use that probe to localize that, and the previously planned software is superimposed onto the patient's body, and we get a multiple image screen in front of us, and that's how we navigate to the different portions of the lung. And I'll tell you what the practical applications are. Because we have this system provides us with access to the peripheral areas of the lung, we can A, do biopsies, B, place fiducial markers for stereotactic body radiation, like Ms. Basso had there, or we can place catheters in there for delivering high-dose radiation without collateral damage, and there's many other practical applications of that, which we talk about briefly. So, I've been using the system for about 7 years now, and there's multiple advances have been made. The computerized software has made tremendous advances, and the procedure has become more easy. When I started using it, I was like the 3rd or 4th system in the country, and now there's more than 350 doctors that are using it. I travel to Minneapolis 2 or 3 times a year, and I train other physicians for doing these procedures. I'm one of the people who helps other physicians train in this procedure, so it is catching up, and it's becoming more and more useful for patients across the country. So we have different types of catheters that we use to twist and turn because, as I mentioned before, there's various angulations. The different angulations of the airways for different people are not the same, so we don't know what we are getting into. So we use all these different types of catheters to maneuver through the various angulations that the breathing tube provides. So this is our system, where, this is my setup that we're doing this procedure on a table, and we have the telescopic steering that is basically how we drive the catheter into the patient's body, into the lung. So, to make it easier for you to understand, let me show you some real case examples. So these are all real patients that I had treated over the years. Most of them are recent, so I just always show recent cases. So, and also some long-term follow-up so that you know that how these technologies improving the patient care as the system evolves. So this is one of my patients who used to be a smoker and then quit smoking for a while, and then he fractured. He was doing some gardening work. He was on a ladder, fell down, and had a fracture. So he was sitting at home, had nothing else to do. His wife left her cigarette and a lighter on the table and went to work, and he was sitting around idle. So he thought, okay, maybe let's have a smoke, and started smoking again. And then he got worried because he had quit for a while and then started smoking again. And he said, well, now that I'm smoking, let me just see if there's anything going on in my lungs. And she had a routine chest x-ray that showed a small nodule, and that was followed by a CT scan. You can see that this lung nodule is way up in the right upper lobe. It's closer to the spine, and it's in the remote corner of the lung. So we did a PET scan to see, what the activity of this is. And the PET scan was very mildly active, so it was not very suggestive of a cancerous process. So we were kind of debating, what would this patient undergo in a real world situation where they don't have these high-end technologies. So if you took out that whole lobe, because this is not something that you can access with a needle, because it's way far into the lung, it's close to the spine, and it's you have to traverse a lot of the lung before you get to this nodule, and it is pretty small, you could miss it. So, and if you take out the whole lobe thinking that, well, this has to come out, what if it is not a cancer because it was not very active with a PET scan? So this also drives home the point that PET scans are not always reliable for making diagnosis of cancerous processes. So we decided to do an electromagnetic navigation on this patient. And this was the actual procedure. As you can see in the 6th panel, in the left bottom panel, you can see how deep inside the lung this nodule is. So this is the safest way to make a diagnosis of this patient's problem. And it was small and it was early. So we were able to make a diagnosis of lung cancer. So this patient actually had lung cancer, even though his PET scan was not very bright and the uptake was not too much. He did have lung cancer, but we caught it early. So he had a lobectomy. This patient is over a year after his lung cancer resection. So he did stop smoking, and he is doing well. He moved to Missouri, but he actually keeps in touch with me, and he wants to make sure that he emails me from time to time to know when he should get the next scan, and and sends any scans that he has to me for me to look at. But we were able to make an early diagnosis of lung cancer in this gentleman, and he had a curative resection. He did not have any notes that were positive during the diagnosis.
Dr. Krishna, we have a question online, but you go ahead.
Danny didn't think I was going to interrupt you. But Danielle wants me to make sure that you address why lung cancer patients need a pulmonologist.
Yes.
Why it's so important. It's, like you said earlier, that we're huge advocates.
Yeah, so, again, so why do we need to do this procedure? Why do we need a pulmonologist? Making a diagnosis of lung cancer is not enough in this day and age. You have to have proper subtyping of lung cancer. There's various gene mutations. There are actionable gene mutations that we know. EGFR is one of them, ALK is one of them, KRAS is one of them. So there's many, gene mutations that are now important for people to know up front. In my practice, it's a routine, and it's amazing in this day and age that how many centers don't do that as an upfront thing, and you have to ask them, and patients have to undergo multiple procedures to, it's bad enough that you are faced with the diagnosis of lung cancer. It is not a good idea to make a patient go through multiple procedures. You do it up front. You do it a thorough workup, when the patient hits your door the first time, and you find out explore all the treatment options, give them the maximum benefit of what you can do about that disease. And that's when, you have to plan this properly. So a pulmonologist is usually a good gatekeeper for any abnormality that is noted in the chest. There is a national lung cancer screening trial that showed that there is a 20% survival benefit for people who undergo CT scan as opposed to, chest X-ray that helps people diagnose lung cancer early. However, most of the nodules that we diagnose with the CT are not cancers. A lot of them are benign processes. So a lung doctor or a pulmonologist is trained to look at these shadows and make a better assessment of what should be followed, on what should be intervened, and what kind of intervention that the patient needs, depending on the location, depending on the patient profile. We're looking at other morbidities or comorbidities. The patient may have heart problems, patient may have had a heart attack, they may be a diabetic, they may have kidney problems. All of those things need to be taken into account as to what procedure the patient can undergo and what intervention that the patient should undergo for providing fast diagnosis, early diagnosis, and accurate staging, and not subject the person to unnecessary procedures. We also are very careful about how we stage lung cancer when we first diagnose them, because surgical upstaging in this country is up to 41%, meaning that the patient goes to the operating room, the surgeon operates, picks up a few lymph nodes and says one of them or two of them are positive, and therefore this patient was not a surgical candidate in the first place. 41% in this day and age, given the availability of all these technologies, is unacceptable. So we always provide them with accurate staging so the patient can undergo appropriate treatment. If you are a candidate for surgery, you should undergo surgery, but if you're not candidate for surgery, that whole time that you spend recovering from the surgical procedure, sitting in the hospital, that will set you back physically, your recovery time, and you will be able to, should be able to tolerate the chemotherapy and other treatment options that come around. And the surgical intervention may take a beating on your overall health. So that is an unnecessary procedure and should be avoided. So for proper screening of abnormalities noted in a radiographic image, for advising the appropriate intervention, perhaps doing those intervention, and proper staging of lung cancer, if that was the diagnosis, can be better done by a pulmonologist. And therefore, every lung cancer patient should have a pulmonologist, in my opinion. Yes, sir.
So I think you just answered the next online question. That was, so why isn't a procedure like the iLogic always done?
Well, it should not always be done, but in the appropriate setting. So for this patient, for example, this is the reason why I showed this case example. This is the only way this patient could have had this diagnosis done in a minimally invasive fashion. This is an outpatient procedure. So think about this. The patient had a small nodule. It was not very PET positive. This could easily be a scar.
I think the question was, why could that patient have been sent directly to surgery for a lobectomy versus doing something minimally invasive?
Yeah, I just answered that question. Right. So if the PET is not very positive, what if this was a scar? What if this was not a cancer? The patient would have lost 25% of his lung. Right. Okay, and this gentleman has risk factors for lung cancer. He does smoke. Okay, and then you lose your 25% of your lung for nothing, for a scar, and the next time he has something, his reserve is limited. And plus, it's an unnecessary surgery for a scar. But so if you know exactly, with this procedure, I can diagnose and stage his lung cancer, and I gave a very definitive treatment option for him, and the surgeon went in knowing that he's dealing with lung cancer and was very comfortable taking out the whole lobe. Now, given the location of this is not someone that the surgeon can go and do a wedge resection, have a small piece of pie for the outside, take it out and look at it in the frozen section at the same time, and then proceed with the lobectomy if it was a cancer. This was so deep inside the lung that up front they have to take out that entire lobe, which is not a good idea if it is not cancerous.
Thanks. And this is also a safer procedure.
Yes, it's an outpatient procedure. Yeah. You go home the same day, and it's safe.
And I think Neil had a question in the back.
Yeah, concerning, so once you made the determination that the person had lung cancer, so of the other 21 procedures that you perform, was there any one that would have been another possibility, either the cryo or the APC in that type of situation, or was resection the only possibility based on where it's located, et cetera?
Yeah, so at this point, resection, surgical resection is the definitive treatment. It's the best available treatment there is. People have compared wedge resection to lobectomies, meaning not taking out the whole lobe, but taking out a small piece of this thing surgically. And that has not been shown to be more beneficial than a lobectomy. So the wedge resection is not beneficial compared to lobectomy. And therefore, taking it out with a cryoprobe or taking it out with the organ plasma or radiofrequency is not considered to be a more definitive option. Today, if someone has a resectable lung cancer, they should undergo resection. That is the best treatment option available. But that may change tomorrow. We'll talk more about that.
And Mary, did you have a question before we go on?
Well, I wanted to ask Dr. If you have stage 4 lung cancer, should you be seeing a pulmonist?
Yes. Well, let me go through the whole talk and then you tell me what you think.
Okay.
Okay.
Do you agree that you're very knowledgeable in lung cancer, but not all pulmonologists have this knowledge that you do. I had a bad experience, and luckily through the foundation found someone that specializes and, or, you know, is really knowledgeable. You're extremely knowledgeable in it, but my feeling is that not every pulmonologist has, they deal with the diseases and the other things, and they all don't know as much about lung cancer.
Well, thank you for the kind words, but I would say that you know, as when we train for lung diseases, we are all trained the same way, including lung cancer. Then people kind of specialize in their own way. For the most part, the pulmonologists see themselves as a diagnostic specialist and not otherwise involved in lung cancer, and that over time kind of translated into people getting less and less interested in lung cancer, not being more up to date as to what is available. So you are correct in the sense, but that goes for most specialties. Mm-hmm. You know, there are cardiac surgeons who are excellent in doing bypass surgeries and valve surgeries, and there are other cardiac surgeons whose statistics are not that great. So that goes for any specialty, but we, you know, because of all these new technologies that are available, this has become a newer specialty, and that's catching up pretty fast. And people like me are going around the country and around the world, basically doing training and talks and increasing the awareness. And, you know, like I said, when I first started doing this, there were very, very few people doing this in the world and in this country. And now there's more than 350 systems, right, Hadley? 400. So every time I talk, there's more. So, and you know, every time I go there now, there's more and more pulmonologists training, and we are a training center at El Camino. We have people come from out of state, sometimes out of the country, to come and watch and learn. So knowledge should be propagated, and everyone should benefit from what one person knows. So this is not something that I wanted to hold on to in my little corner at El Camino Hospital. This is something that everyone should learn, and we are making a lot of effort in helping people learn. So I go proctor them, and I proctored a physician today who will be practicing out of San Francisco, and will be starting this very soon. So. So this is a truly amazing patient case example that I wanted to show you. So this lady is a very active lady, and she actually, you know, plays tennis, you know, 3-4 times a week. So, but she had a heavy cigarette smoking history, but she quit smoking in 2005. But given that, and given, so she meets the criteria for the screening CT scan. And someone said that CT scans are great, and if someone needs, you said that. So yeah, so screening CTs in high-risk patients are beneficial, and she actually benefited from this tremendously because she insisted that she wanted a CT, and her pulmonologist actually was already sold on the idea that screening CTs are beneficial. So she did get a screening CT at Stanford, and she had this very tiny lung nodule right smack in the middle of her left lower lobe. The arrow points it. It's actually, when it was first diagnosed, it was about 6 millimeters, and in 2 months they repeated this, and it grew to by 2 millimeters. You know, 2 millimeters is like, you know, 25 millimeters is an inch, so it's very, very small. You know, it's like 1/10 of an inch or even less. So 8 millimeter nodules. So most centers don't know what to do with an 8 millimeter nodule. People usually typically follow them clinically. Okay, let's get another CT scan in 3 months. But we did not. We went ahead with the electromagnetic navigation and did a biopsy. She had small cell lung cancer, which actually is a more aggressive form of lung cancer. So the interesting thing about this whole thing is that if you look at the literature of small cell lung cancer, most of the small cell lung cancer that is diagnosed at that stage are diagnosed during autopsies, or if the lung was resected for some other reason. Targeted biopsy of such a small lesion for small cell lung cancer is virtually unheard of. And because of this technology, we were able to make that diagnosis. So, and we did a PET scan and an MRI because small cell lung cancers tend to spread early. So it is always important to scan the brain because PET scans are not reliable in making diagnosis of brain lesions. And therefore, we did an MRI. The MRI was negative. The PET scan only lit up that area, nothing else. So we had multiple tumor board discussions because this is a new, small cell lung cancer having diagnosis is early. But we wanted to give a curative option to this patient. So she underwent lobectomy. She had a left lower lobe removed. And at that time, they actually did, I believe it's 17 lymph nodes they dissected during the lobectomy. All of them were negative. So she had a truly early stage small cell lung cancer, which was one of the most gratifying things that I've done in recent times. So we were able to get that out. And this is a very active lady. She's back up and about doing her stuff, very active and back to her old lifestyle.
Oh, thank you.
So, well, do all lung nodules need to be resected? So that's another question. So, the two examples that I've shown you before, both of them ended up having surgery. So clearly the question comes up, someone already asked that question, so why not just take it out? Why do you do all these procedures? So here's an example for that. So he's a 57-year-old man of Japanese ancestry. Even though he's of Japanese ancestry, he was born and raised in the United States. The only foreign country that he's visited is Italy. And he had some cough and respiratory symptoms. And he had a 12-millimeter nodule, it's about ½ an inch, in his right lung, which was mildly PET positive, not very hot. So he did see a thoracic surgeon who said, well, let's just take it out. This could be cancer. So he also had small lymph nodes that were mildly PET positive. So these are his pictures. You can see that there is, can everybody make out what the abnormality is? Unfortunately, my pointer is not lighting up on this thing. So you can see that that's the nodule there. Still not lights up. So you can see that that's the nodule on the right side. Okay, so the right lung is your left. Okay, if that helps you understand this better. No wonder medical science is so complicated. So, and so that's a small nodule, and it is also in the middle of the chest. So again, if you talk about can we just do a wedge resection, get a pie-shaped resection, that's not possible in this case. You have to actually take out the whole lobe. So we did electromagnetic navigation. This was a while back, so we had the old system. And you can see the probe of the electromagnetic system on 3 different axes on the same nodule. So we did a biopsy, and this was the result. So he had a parasite. So obviously I wasn't thinking about a parasite in someone who was born, raised in the United States. So I called him up and said, what do you do? Do you do something different than the rest of us? So on talking with him, I found out that he actually frequents this Bay Area restaurant. I'm not going to tell you what that place is. And they import these crustaceans from Northern Asia, especially from Korea. And they actually dip them, it's called drunken crab. So they dip them in wine. So it actually kills all the bacteria in the parasite, but in the crustacean, like a crab, but it does not kill this parasite. The alcohol or wine does not kill this. So this was a female parasite in there, and there were eggs, and there was a whole family in there. So, well, untreated.
Now we're all freaked out.
You're all freaked out?
Yeah.
Okay. Well, I haven't had sushi since, so. So untreated Paragonymous westermanni is not a benign disease. It has a 5% mortality. It can cause strokes, and it can cause dissemination. But this patient did not need his right upper lobe taken out. All he needed was a medicine called praziquantel. So I treated him with praziquantel for 3 days. So that is a nodule, and now that is reduced to a scar. So this is another reason why anyone with a CT scan abnormality or radiographic abnormality should have a pulmonologist. So you don't, again, this answers the question as to not everything needs to come out. So there are benign causes where you go and make a biopsy and it shows that it is a benign cause, it is a treatable condition. All he needed was 3 days of praziquantel, which is an anti-parasite, and he's cured. So it is important to go to again, this is a multidisciplinary approach. Everybody brings something to the table, and everybody contributes to provide a minimally invasive, best outcome, maximum treatment option for the patient for whatever disease process they have.
So, Dr. Krishna, it looks like our online viewers are drinking caffeine instead of wine because they're very active tonight. So you have sparked a lot of interest in the whole pulmonary pulmonologists being on their team for lung cancer. So first question is, lung cancer patients, I'm guessing this person has a compromised system. But isn't seeing a pulmonologist. Should a pulmonologist be involved, I guess it's after the fact, for pulmonary function sort of after the fact?
Yes, I think, well, that goes to the same question. So someone with stage 4 lung cancer, should they see a pulmonologist? Yes, the answer is yes. Well, Mary asked the question actually. So so yes, and there are various reasons for it. As we go through the talk, that will be fairly evident.
Okay, to help with compromised pulmonary function.
Correct.
Okay.
Other questions?
Well, one was again about pulmonary deficiency from having lung cancer and how a pulmonologist can help. But it sounds like if we just get through you're going to cover all of that. So yes. Thank you, online viewers, for being so active.
Okay, so, well, are we serving coffee here?
Exactly, I know. No, we like wine.
Okay, so this is another great example of timeliness. So one of the important things that we always need to do, so if you look at, we were talking about this before this session, that the time from initial radiographic diagnosis to when the patient hits the specialist who offers definitive treatment, be it surgical intervention or chemotherapy. What do you guys think the time frame that happens in this country? From time from initial radiographic abnormality, be it a chest X-ray or a CT scan, to the time that someone hits the door of a definitive treatment. What would be your guess? 3 months? Right on. So it's actually 90 to 120 days, and that's unacceptable. So one of the things that we always focus on. But then if you dissect out as to why that happens, so someone gets a chest X-ray, takes a couple of days for the internist who ordered the chest X-ray to look at the reading that was given by radiologist. It may be a routine chest X-ray, so the radiologist is not going to get to it right away. So 2 days later, after taking care of all of that other paperwork, the internist finally looks at the chest X-ray and says, hey, it looks like there is something at distal. So, well, what do we do with distal? So sits on it for another couple of days and then thinks about it. Maybe I should order a CT scan. So he orders a CT scan as a routine, and then that takes another 10, 15 days for it to schedule. And get the CT scan. That takes another 4 or 5 days for the internist to look at it again. Oh, that looks abnormal. Should I, send the patient to, should I get a PET scan? Should I do this? Should I see a pulmonologist? And then that takes another 2 weeks. And then the pulmonologist sees this and sends it to the interventional radiologist, who takes another 2 weeks to do the biopsy. So if you look at it, like dissect out what really happened, this actually takes a lot of time. Another reason why I think in my setup, yes, sir.
Don't forget about time to get a second opinion.
Oh, Dave,
of
sorry,
course.
we need the microphone.
Yeah. Allow time to get a second opinion.
Of course, when you're faced with a big procedure, like you say surgery, nobody's going to accept, one person's word. You're justified, perfectly justified in asking for a second opinion if you've been recommended a big surgery. Extrapleural pneumonectomy is not a small procedure. So, you can have multivarious reasons as to why things take more time. So in our model, the pulmonologist is a gatekeeper. So we get alerted of all abnormalities that in a chest, and we quickly determine who gets what and how quickly it's be done. So we would like to get the time from initial radiographic abnormality to the definitive treatment to be 30 days or less. That should be our goal. And we have just initiated a program for that with a nurse navigator, where we give the option for all the primary care providers to just call that one person for any abnormality that they know they don't want to they are not capable of following or they don't want to follow, that we will do. In a community setting, it's a little bit more difficult. When I was in a more, at the VA, we had this program like this. It's a closed system. So we were able to bring down that time frame to less than 30 days. In a community setting, it's a little bit more difficult, but we are launching that program, and that's our goal. And I think that should be the goal nationwide, and it's very, very important. And if you look at lung cancers, we look at tumor doubling time. The most aggressive of lung cancers have a doubling time of about 45 days. And the least aggressive of lung cancers have a doubling time of about 890 days, about 2.5 years. So, and a lot of them are in between. So given that, I think a 30-day goal from initial radiographic abnormality to time to definitive treatment should be short. So here's an example for that. So this is a gentleman who had a head aneurysm and was not surgical, so they were just following him up with sequential CT scans. And the head CT actually covered portions of his neck and therefore the upper portion of his lung that showed an abnormality. So this was the abnormality. So he had 2 intensely PET-positive lesions on either side, the right side and the left side. Now, so what, in the setting of lung cancer, what could this be? So this could be a 2 synchronous lung cancer, which is most likely, because if it was a cancer originated in one place and it goes to the opposite lung, it usually makes a stop in the mediastinum where there's lymph nodes that are positive. Now, this gentleman did not have any of those lesions in this middle of his chest. He only had it on both lungs. So what would normally happen? So you go after one, and then you wait, and then you go after the other for diagnosis. That's a time lag. So I was, with the electromagnetic navigation, I was able to biopsy both of these lesions at the same time. And he did have lung cancer on either side. So he did have adequate lung function. So he had a curative resection. He had both the upper lobes removed sequentially. So we were able to get him this definitive treatment very quickly by biopsying both of these at the same time and proving that they both are cancers and proving that he had adequate lung function to undergo the surgery that he needed. And I think that's where a pulmonologist comes into play. So you can actually have selective perfusion scans. So we are trained to do those things. We can make the pre-surgical assessment. So, the lung constitutes of blood flow and air. So how much of air and blood that is in different lungs, and we can subtract the amount of lungs that are going to be resected and then deduct that from his total lung capacity and find out how much lung will be left behind after both the lobes are removed. And we can make that assessment with one test and provide the surgeon with that information, saying that this patient can undergo both lobes to be removed, undergo the surgery where both lobes can be removed in sequence. So another, role for the pulmonologist there.
We had one question. Penelope.
When would you do like a wedge resection versus target radiation? Is it all based on size of the tumor? Or?
That's a good question. So, so the conventional thinking, which most people practice, is that when you do targeted radiation, such as stereotactic body radiation, when you say targeted radiation, that's what you mean. So when you do SBRT, generally it's done for patients with significant comorbidities who are not able to undergo surgery. So if the patient has severe lung disease and will not tolerate a resection, or the patient has severe heart disease that will not tolerate anesthesia, then, and single lung ventilation for the procedure, then targeted radiation is a good option. Having said that, the data that has been accumulated over the years regarding stereotactic body radiation is good enough that there is a randomized trial randomizing patients who otherwise would be surgical candidates and allowing them to undergo SBRT as opposed to surgery. So people are being randomized. MD Anderson is spearheading this trial, and we have 2 arms of stereotactic body radiation and surgery. So I think one of the downsides of doing SBRT is that you won't be able to do lymph node sampling, that you may not be able to accurately stage them during the surgical procedure itself. However, with the technologies that we have now, which I will show you, like endobronchial ultrasound, we can easily stage these patients prior to undergoing, sending them to one of these treatment options. Some patients undergo SBRT just purely because of preference. They just don't want surgery. So, this is SBRT these days is also done with a curative intent. Did I answer your question? So this is another example of a computer engineer who went to Costa Rica, had skin lesions. He had the skin lesions were biopsied and they was non-specific. So he had some fungal studies that were also negative in his urine. So he had 3 abnormalities in his CT scan. And I was able to biopsy all of those 3 and came up with 3 different diagnoses. So he had a lymph node right around the bifurcation of his breathing tubes underneath. That was a lymph node. And he had this nodule you can see in the right upper lobe.
Do you want my pen?
Yeah, something longer.
Longer.
Can he borrow somebody's arm?
Long arm, preferably.
Jennifer's looking for a stick. Something.
Okay, so anyway, so that's the nodule on the right side, which is your left, and also those cluster of nodules. So I biopsied all of them at the same time. So the presenting reason why he actually came to me, well, the smooth nodule that he had ended up being a carcinoid. It's actually a tumor. So he probably had it for a while, and because he had this additional finding of after going to Costa Rica, we were able to find that. But we didn't miss that diagnosis. We were able to biopsy that. And then his lymph node actually showed this fungal infection called coccidioidomycosis. You might have heard of, it was histoplasmosis. You might have heard of valley fever. Mm-hmm. So similar to valley fever that is endemic in our area, like the East Bay or Arizona, histoplasmosis is a fungal infection that is endemic in the, in the Ohio River Valley and also in Mexico and, Costa Rica. So he, because of his trip to Costa Rica, so that's what actually brought him to me, but we gave him the additional diagnosis of carcinoid. So he got lucky.
We need a microphone really quick, sorry. Right there, right behind you.
How long was this patient exposed in Costa Rica?
Well,
to histoplasmosis.
Yeah, so, the duration, he was there for like 2 or 3 weeks. But people can get, I've seen people get coccidioidomycosis just by driving through Southern California with, the car vents open. So it is a matter of susceptibility. So you don't have to be exposed to it for a long time for you to get the infection. So, but this gentleman actually went caving and all that in Mexico. He was very active. He was doing a lot of stuff. So he was, exposed for quite a bit. Like the load was more.
Thank you.
So and then the cluster of nodules that we biopsied was a reaction to the histoplasmosis called bronchiolitis obliterans, which actually, modifies the treatment because we gave him steroids for that and antifungals for the histoplasmosis. And then after he got treated for the histoplasmosis, he got this carcinoid resected. So this, carcinoid is quote-unquote a benign tumor, but it can behave in a very malignant fashion. So if you find a carcinoid, it has to be removed. And he had it removed. And he's almost 2.5 years out of it, and he's doing great. So this is another interesting case. This is a gentleman who's very active. He does competitive rowing. And he actually, this was one that I did at the VA, Palo Alto VA. So he actually came to learn computer skills in the blind rehab program. And someone ordered a chest x-ray by mistake. So when he checked in, so they were just, VA has an excellent computer system. So they just went click, click on the chest x-ray part, and he got a chest x-ray, which ended up being a good thing for him. So he did have a smoking history in the past, and he had all these other history. So he had this chest x-ray that showed this. Do we have the stick yet? No. Okay, so we had this right upper lobe, little pulmonary nodule, which was pretty subtle. So credit goes to our radiologist who picked that up, which is very neat. So obviously this was followed by a CT scan. He had 2 lesions, as you can see. The one in the upper, the right lung, which is to your left, and this nodule. And then there is another small ground glass opacity in this right lower lobe. So I biopsied both of them. So he had a PET scan. The upper one was positive. The lower one was not. So what would you do in this situation? So I biopsied both of them at the same time, and both of them were lung cancers. So the ground glass, they both come under the classification of what was formerly called bronchoalveolar cell carcinoma. But that term is largely now rejected. It is a type of adenocarcinoma. They typically tend to be a slow, indolent tumor. But if they have solid components, they could behave aggressively. So because he had that adenocarcinoma in the upper lobe and BAC in the lower lobe. He had adequate lung function, so his right upper lobe was removed, and we did a wedge resection of the lower lobe of that tumor, thinking that this is an indolent tumor and that would give him, adequate cure. And he did great. I mean, I was following him for the next 3 or 4 years, and he was doing fine. I no longer go there, so I don't have a follow-up information, but he had a curative attempt and did well.
Esty, can you grab the microphone?
How often do you find that ground glass type of spots that are found in the lungs are cancerous? Because most of the time they're not, I've been told.
Well, it's actually not. So let me get the mic back from you. So the question was, how often do you find ground glass and how often they are cancerous? If you look at all comers with lung nodules, ground glass nodules are more likely to be cancerous than solid nodules. So it's, yes, so ground glass nodules can be something else. It can be inflammation, but if you look at the likelihood of a ground glass nodule is being cancerous is more than that of a solid nodule. But having said that, the ground glass nodules, the cancers tend to be more indolent, more slow growing. And that's another important thing to know for those of us who are interested in lung cancer, that the general recommendation that we follow from American College of Chest Physicians or Fleischner Society is that if the nodule is being followed for more than up to 2 years, and if they don't grow, that means they are less likely to be cancerous and no further follow-up is necessary. It is not true for ground glass nodules because they tend to be slow, so indolent. We do have to follow these ground glass nodules for longer if we choose to follow. And in a center like ours, we intervene. We do biopsies.
Because mine haven't grown in 7 years, but they're there.
Which is typical. Yeah, so it is an indolent, slow-growing. Yours was a ground glass, and it was a bronchoalveolar cell, right?
There are quite a few ground glass on the other side. But I've been told by Stanford that it's very unlikely, and David Jablons didn't think that most of the time they are cancerous, so I don't know.
Well, I wouldn't say most of the time. I mean, maybe that's not what he meant. But, if you're followed by 7 years, so they still are following this, right?
Yeah, once a year.
So because they're slow growing.
But they haven't changed.
Well, I know. Slow growing means not visible change every year, so you have to follow it for longer. So clearly they are concerned enough to do annual CT scans.
Yeah, well,
so that, the moment anything shows signs of growth, I think one of them should be biopsied.
Oh, yeah.
And is that then a candidate for the iLogic, the superdimension technology that you were talking about?
Well, depending on the location, yes, of course.
Excuse me.
So,
Here.
Oh, sorry.
Exactly what is ground glass? I have that on my reports all the time, but I never remembered to ask.
Okay, so if you, the good analogy would be, so if you've seen someone behind a shower, there's glass door, you can tell that someone is behind the glass door taking a shower, but you can't quite tell who. That's ground glass. Okay, similarly in the lung, if you are unable to see the lung structures very clearly, but kind of hazy, like a veil-like opacity on top of it, that's ground glass. And it's usually well defined, not throughout. Ground glass, if it is throughout the lung, sometimes it can indicate heart failure. But a circumscribed area of ground glass is somewhat worrisome in the appropriate clinical setting. Any other questions? Yes, sir.
Can I ask you a carcinoid question?
Yes.
That's actually what I have. My name is Brian. Sorry, I thought I was going to have to leave, so that's why I was sitting back here. So I was diagnosed stage 4, February 2010. I have a bronchial atypical carcinoid tumor, and it actually had wrapped itself around the bronchus to my left lung, collapsed my left lung when I was diagnosed. And so they said it's basically inoperable. So I've actually been on Afinitor for 1.5 years. I've been stable. There's been no reduction. So they were hoping for an eventual reduction in this before, I believe it was called radio, I'm sorry, I can't remember. One of the other, they were talking about putting a seed in the where the tumor is and radiating.
HDR, brachytherapy.
Yeah, brachytherapy, I'm sorry. Yeah, that's it. Yeah. So does that sound right? I mean, I feel great. I don't barely have any side effect anymore on this medication, but I'm a little concerned, if it stops, working, so.
Yeah, I mean, it's, well, depends on the location and where it is. If it is outside wrapping around the airway versus it's inside the airway blocking it up, it's different.
Yeah, no, it was outside. Actually, was they did a bronchoscopy and there was nothing.
Okay.
There was no, so they think it's completely around the outside of it.
Right. Yeah, it's completely outside the airway. I think it is going to be difficult to do HDR
really?
brachytherapy on it. So brachytherapy is typically, well, I do this brachytherapy with the insertion of catheter in otherwise inaccessible lesions.
Mm-hmm.
So the general application of brachytherapy is that if it's for airway tumor, they insert the catheter, place the seeds, and then do high dose. That's why it's called HDR. You do high dose radiation because it's so selective. You don't cause much collateral damage. You're able to do more brachytherapy on it.
Mm-hmm.
If it is outside the airway and if it is growing, then stereotactic body radiation may be a good option.
Okay.
We could place this fiducial marker across the airway with endobronchial ultrasound, and then you can actually have that radiated. There are, I mean, again, you have to be careful as to the radiation oncologist that you choose because not everybody is skilled to radiate something that is more proximal to the big airway.
Yeah.
In our center, we do that, and we actually, there is a 5 to 10% chance of fatal bleeding if you radiate a big blood vessel close to the chest. So it has to be done very precisely. So placing a fiducial marker with guidance and radiating, that would be a better option compared to HDR brachytherapy. However, I'm saying all of this without looking at your picture, so I may
of course,
feel differently
no
when
one
I see
brings
the
up
picture,
carcinoids,
but
so that's why I thought I'd ask.
that's basically the option. But again, carcinoids, again, are slow growing, and they can change directions. They come under the classification of neuroendocrine tumors, and some of them actually spontaneously regress and go away.
Oh, well.
So, neuroendocrine tumors are funny. So the other end of the neuroendocrine spectrum is small cell cancer, which is extremely aggressive.
Mm-hmm.
But the cell rests from which they arise, the embryonic cells from which they arise, have similar ancestry.
Oh, okay.
But the behavior is very different.
Okay. Well, thank you for your...
So this we already talked about. So both of them were cancer, so this patient had a wedge resection as well as the upper lobectomy. Okay, so we'll move faster because I think, wow, we already got, so we have a lot to cover. So this patient fell down going to her niece's house and broke multiple bones in her body and was admitted to San Francisco General on the trauma unit and was basically told that they fixed all the bones and said you have bilateral multiple cancers and you're going to die. And did not do a biopsy. They sent her home. So she came back and she came to me, and I saw this and I was very worried because you can see there's multiple abnormalities on both sides. And for that degree of tumor burden in her chest, she looked pretty good, even after undergoing all those fractures. So I thought, okay, something is amiss here. So biopsied that. It ended up being a benign tumor called hamartoma. So what is hamartoma? If you have suppose you cut your skin, the skin grows, the cells grow, and they meet each other, and then they stop. That's how a scar forms. So they know when to stop. That is called contact inhibition. So they come into contact, they stop growing. That contact inhibition is lost in the lung in certain areas. So the normal tissue kind of continues to grow, and they don't know when to stop. But otherwise, does not demonstrate any other malignant characteristics. So this is a very rare form of tumor. So again, this could be biopsied only with the forceps. So if they had passed a needle through her chest wall to make a diagnosis, this would have not been possible. And I was also able to biopsy multiple lesions and showed the same tumor that, they're all the same category. So she had a hamartoma. It's called Cowden's disease. So that's a special stain that actually shows that. It looks colorful, but it's a benign tumor. So moving on. So stereotactic body radiation, which is something that we talked about. So this is the fiducial marker that I place. So again, I'll show you a good example of this. This is a 77-year-old lady with metastatic colon cancer. She had a lesion above her aortic arch. So that white circle that you see there is the aorta. That's the biggest blood vessel in someone's body. And right on top of that is a tumor sitting there. So that's not an easy location. So this is not something where you can radiate very safely. And if you radiate the aorta, it's bad news. So I was able to place fiducial markers. You can see in the X-ray, there's one I placed in the center, one right in the inferior pole, and one in the lateral pole. So that we can also use the spine as one of the landmarks. So he had 4 landmarks. So the radiation was more precise, right on top of the aorta, and we were able to give her a curative radiation to that metastasis, and she's doing very well. And this is also an example where she has a pacemaker. So some people, actually superdimension says that it is a relative contraindication because they have not done any testing on patients with pacemaker. I have done several cases on that. We do take adequate precautions, call the pacemaker company, but we have done it and it's fairly safe. So this is another gentleman with metastatic rectal cancer. So this is not just lung cancer. Any thoracic malignancy, we have ways and means to help people with all of these procedures, is the point I'm trying to make here. So I placed a different kind of fiducial marker. There's pictures of all these markers there. It's called a super lock fiducial marker. Each of those nodes actually serve as a marker for location of the tumor. And I placed 3 such markers in this gentleman. And it is right behind the heart, so it's not very easy to see. And he underwent SBRT. So this is a gentleman who was followed in UCSF. He had multiple cysts in the liver, and some of them are compressing on his big veins, the inferior vena cava. And he had a CT scan for follow-up of these nodules, and he had a lung nodule in the lower lobe. So you can see that the smooth lung nodule, which is close, and he had a PET scan, and this nodule lit up, and none of the liver cysts lit up. So we did not think that there was a relationship between them. So I did electromagnetic navigation on him, but I was unable to get a biopsy. But what I did was I placed these fiducial markers right next to them so that my thoracic surgeon can go in and localize them better. Because feeling them, these nodules, is not very easy because it is too far deep down. But when I place metal, they are able to look at it and feel it, and was able to selectively resect the. So you can see the fiducial marker. So that's the tumor that was resected. It was cut and open. So imagine that was how the tumor was. And the fiducial markers are sitting right next to it, showing that it was precisely placed there. And this explains why I was not able to get a diagnosis there, because this is a type of tumor that you cannot get a diagnosis with just a needle biopsy. It was a primary pulmonary sarcoma. It's a very rare tumor. But this patient did not lose any extra lung. He was able to have it resected. Okay, moving on to staging. So these are...
Question for Neil.
Yes.
Do you ever, as part of the work, introduce a drug into the tumor itself? Rather than doing a systemic or targeted oral type thing, do you ever put the drug directly into a tumor as part of your work?
Not yet, but that's the future. There's rather than putting in drugs, there is a Turkish group that actually did that. They did place medications such as carboplatin inside, but it really didn't provide that much benefit. But as in the days of targeted therapy, where there is more molecular targets that are available, this could potentially be a great opportunity to use these minimally invasive techniques for instilling targeted therapy without collateral damage. And that's basically one of the research projects that we are focusing on. I'll talk to you about that briefly towards the end. So, well, there are multiple lymph node stations that we already talked about, surgical upstaging, and we need to provide appropriate staging to the thoracic surgeon to avoid unnecessary surgery. So endobronchial ultrasound actually does that. It's a very high resolution ultrasound. So you can see the airway in 7 different layers. So this provides you much better resolution than a CT scan. So the various types of ultrasound will move through this. So that tells you the black arrow is a normal wall and the white arrow is a tumor. So you have to have some training in reading the ultrasound. It may just look like a black and white picture if you're not trained. So these, again, we'll go through this quickly. So this patient had a very tiny lesion behind his breathing tube. The arrow is showing you the tumor. So he was vacationing in France when he had blood come out of his urine. He had a workup there, and they found that he had a kidney cancer, and he had left kidney removed for that. And he came back to the United States and he had that. And he was told that, okay, this is a small nodule, there's nothing we can do, we just need to follow this. But he found out about our program, he came to me, and I was able to biopsy that, and it was actually a metastatic renal cell carcinoma. That was the only abnormality that he had. So he underwent further therapy without any more delays. So this lady actually had symptoms of pneumonia after she went to New Zealand. So that was a pneumonia initially, but the pneumonia resolved, and the follow-up CT still showed that abnormality there, which was persistent and wouldn't go away. So I biopsied that with endobronchial ultrasound. As you can see, it is located in the middle of large blood vessels. So you really don't want to puncture any of those blood vessels, and that can be a bad thing. And so we were able to biopsy that precisely with the endobronchial ultrasound, and that was a carcinoid. So she had a resection, and it's been more than 5 years, and she's doing great. So this is another interesting patient. So this lady had incidentally diagnosed breast cancer. She went for a physical, had a chest x-ray that showed fullness on both sides of her hilum. So she had, someone sent her straight to PET scan. So she had a PET scan that actually showed, you can see on her right side, the breast lit up. That's the breast cancer, which was biopsied. It was breast cancer. And then you can see that entire mediastinum, there's multiple lymph nodes that all lit up. So she was told that she had metastatic breast cancer and has a poor prognosis. So she came to me for a second opinion. And again, you know, why should a pulmonologist get involved? I looked at the scan and I was kind of concerned because, or a little puzzled because a breast typically goes to the armpit, to the axilla. So this, if all of that lymph nodes in the chest were cancerous, they're not following the normal anatomical rules that we learned in medical school. So something's wrong with this situation. So I thought those lymph nodes should be biopsied. So we used endobronchial ultrasound, and I biopsied 5 different lymph nodes in the chest in the same sitting. Which again is not possible with even a surgical approach. We were able to biopsy on both sides. And she ended up having sarcoidosis, which is a benign disease. So with just that one procedure, she went from, oh my God, I have metastatic breast cancer, to curable breast cancer. So she just had a lumpectomy. Sarcoidosis is a benign disease of a lymph node and does not need any treatment. So that was probably what they saw in her chest x-ray that she had as a routine during her physical, but they did diagnose the breast cancer, and that was an early stage as opposed to, suppose they never really bothered to diagnose these lymph nodes and assumed that she had metastatic breast cancer and treated her accordingly, that would have been a disaster. So PET scans are not reliable because sarcoidosis lights up too. So PET scans are not reliable in some of these situations. Okay, so this is another 38-year-old non-practicing physician from India. She's raising like 3 kids, and she had a fat pad inflammation. We call that erythema nodosum, which is usually a marker for sarcoidosis. If you have erythema nodosum and lymph node, it usually is sarcoidosis. It's a very classic symptom. But when I biopsied these, I biopsied multiple lymph nodes at the same time. So, you know, we always are taught to think that Occam's razor dictates that is one unifying cause for all presentations, but it's not oftentimes true. So when I biopsied, she had sarcoidosis on the right side and lung cancer on the left side. So she had 2 diseases at the same time. And so it was still a surgically resectable stage in the sense that she needed a whole pneumonectomy, but she elected not to do that. And we also did EGFR and ALK gene mutation like we routinely do in all our patients, and she was positive for one of them. She's still undergoing chemotherapy, and she's doing okay. But she had 2 separate diseases. So in this situation, again, either for future staging or treatment response, PET scan is going to be unreliable for her because sarcoidosis lights up too. So again, if someone undergoes a mediastinoscopy for making a diagnosis, repeat biopsies in that situation is also going to be not possible. So again, endobronchial ultrasound is a very useful tool in those situations. Okay, I'm going to go a little faster. So this patient had a quick growth in the interval, so that's the right upper lobe lesion. So this patient had a PET scan, which lit up very strongly in the right upper lobe. But you see that in front of the trachea, he had a lymph node that was actually PET negative. But when I biopsied that, it was lung cancer. So this patient, if I just went by PET scan and biopsying just that right upper lobe nodule, would have been a surgical candidate, quote unquote. But he would have gone to the operating room, had that lymph node removed, and would have found that it is an inoperable cancer. So he would have undergone a big surgery with loss of 25% of his lungs for no good reason. So we were able to save him that, and we were able to get him to the door of a person who would provide him with definitive treatment, who was the oncologist, not the thoracic surgeon in his case. So staging is very important when lung cancer diagnosis is made. Staging is very important when reevaluating after treatment. Staging is very important throughout lung cancer treatment. So we already showed you that. So we have submitted a manuscript with one of the highest diagnostic accuracy in the world. My diagnostic accuracy for EMN is about 92%. So we're fairly well established center, and our complication rate is also very low. I've had one lung collapse in like 2.5 years, and that too did not require any chest tube placement. So this is a valve that is placed inside the lung for patients with COPD, just to switch gears a little bit. But I use this device also for another reason. So someone has a lung surgery and they start leaking, making them stay in the hospital for a long time. I place this valve which allows airflow one way, and it actually helps the leak stop. So we size it with the balloon and place that valve there, and that little knob there is something that I can hold and remove at a later date once the leak is sealed. So I had very good success with this. I'll give you one example. So this gentleman had a rupture of one of his bulla because of COPD. He's in his 80s. And he had a chest tube placed, and then air started leaking throughout. So the air went under his skin all the way to his head and his toes. He looked really inflated like Michelin Man, and you touch his skin, it's like Rice Krispies. It went under his eyelid, and both his eyes were swollen shut. And he became very delirious because he was an older gentleman, and he was away from home. He was in a hospital. He couldn't see. He became very delirious. He tried to jump out of bed and fall down, risk of hurting himself. So I placed these valves. You can see those valves right there on the right side, which is your left. And you can see the air still under the subcutaneous area. So within 2 days of placing the valve, he shrunk to his normal size. His chest tube was removed, and he went home. So this is, again, something, a leak in the airway is not an uncommon complication after lung cancer surgery. So this is another very useful tool. It's a minimally invasive technique. It's done as an outpatient, decreases hospitalization, and this valve can be removed at a later date.
Does it always have to be removed?
No. Great question. So for COPD, actually one of the patients that I placed this valve for a leak had COPD, and I told him initially that we could take this valve out if we after 6 weeks. And after 4 weeks, I saw him and I said, we can schedule removal of the valve. So he had COPD, so the valve was primarily designed to compress the abnormal areas of the lung that is affected by COPD and allowing the normal lung to expand. So he was feeling so good with this valve. So he got all upset when I said that I'm going to remove this valve. He said, it's my valve, you're not removing it. I said, okay, you can keep it. So the valve can stay in forever. It doesn't cause any problems, even if the patient needs an MRI in the future. If you go through an airport, the alarm is not going to scream, and Homeland Security guys are not going to jump all over you. So it is made of platinum, so it doesn't cause any interference. So this is a treatment that we use for asthma. We use a catheter to use radio frequency for severe asthma patients. I've had some really good stories. I mean, patients, asthma is a big health problem, and I had a patient who gets intubated on a respirator every 3 months. He's 39 years old, and he was on steroids, big face, weight gain. So he was sent to me from Kaiser, and I did bronchothermoplasty on him a year and a half more than a year and a half ago. He's not even had an unscheduled doctor office visit after that. So there are people with other diseases that suffer tremendously, asthma, as you all know, and he benefited significantly. And to date, I have done the most number of bronchothermoplasties in the world. And we have pretty good success rate with this. And we are now exploring options of using radiofrequency catheters for lung cancer, using the same technology with modifications. So we are looking into that as a treatment option for lung cancer, where we can insert this catheter into tumor and kind of cook it. So this is a patient that I will remember for a long time. The patient came to me, basically came to the hospital to die. So the patient was 58 years old, had lung cancer. The entire lung was collapsed. She was on like 6 to 8 liters of oxygen and saturating barely in the mid-80s. And I was at Stanford at the time, and the resident who was taking care of the patient said, can you look at this patient and can you do something? Because it was this time that I first started doing these procedures. So we looked at it, and when I talked to her, she actually said, her story is actually with her picture is on my website. So she said, I'm 58 years old. I wanted to celebrate my 60th birthday. Can you do something about it? So I said, well, I'm going to try. So we recanalized her lung. She actually walked out of the hospital on room air and went on to live for another 5 years. I did 3 other procedures on her, same recanalization in the next 3 years. She was able to see her grandson graduate from the fire academy. She had a real blast on her 60th birthday. Mm-hmm. And she passed away when she was 63 and a half due to bleeding from her brain mets. Her lungs were still fine. So this was ironically, the day that she checked into the VA to the hospice on the day that she passed away, and I actually, for no good reason, I decided to visit the VA that day to see an old friend. And that was the day that she was, so I was able to go there and say goodbye to her also. So she is a very special patient of mine that I will always remember, and it was one of the most gratifying things that I've done in my life. So this is another patient.
Time's almost. I just want to make sure everybody gets a chance to ask questions.
Yes, so 5 minutes, or we'll be done in 5 minutes. Yes? Okay. 3, okay. She's a good bargain. Okay, so this is a left lung that is completely occluded with tumor, and I use APC and cryo to recanalize that, and that's after recanalization. The airway is completely open. So this is a CT scan, so you can see the left lung is completely collapsed, and this is afterwards. This is a patient with metastatic colon cancer. She's 52, and she has a husband who has multiple sclerosis, so she actually takes care of the patient, and she's the sole breadwinner of the family. And she runs a daycare. So she was obviously not able to walk about or run behind daycare kids with her entire left lung collapsed. So I was able to recanalize. You can see that there is still residual tumor in there, but her lungs are full and expanded in the left lung. So she was able to go back to work and take care of her husband. So, this is a very difficult social situation. She's not even able to talk to her husband about her problems because he was, advanced stage dementia. So this was a very difficult situation, but we were able to help her. So this is a disease called relapsing polychondritis, where the trachea, the breathing tube, completely collapses, and we place stent on the trachea and the 2 mainstem bronchi and actually reconstructed the whole airway. So this patient actually had a life expectancy of less than a week, and I'm happy to report that it's been close to 2 years since I reconstructed his airways, and he's employed full-time. So this is another lady, we did the same thing. This is a transplanted patient where the transplant stenosed. As those of you who have a background in physics knows that the airflow across a tube is proportional to the 4th power of radius. So you can imagine that 1 millimeter tube, if I dilate it to 2 millimeter, the flow increases 16-fold, 2 raised to 4. But that is more than that. So you can imagine how the patient felt before versus after the procedure. So this is thoracoscopy. This is a patient with metastatic breast cancer. We did pleurodesis. So that's the pleurodesis procedure that I do in the OR. This is a talc that we use. This is a patient with metastatic lung cancer, where we use the talc to stick the pleural membranes together so that the fluid doesn't secrete. This is before and after. This is how the patient showed up. This is after pleurodesis, before discharge.
Dr. Krishna, can you just very quickly say to me your contact information? We have our online viewers who are saying before we end and they get blacked out, we need to give them your online information. And we also want to tell everyone that we will post the presentation on our website so that everyone can go and view it.
Actually, that's my website here, pmf.org/pulmonary/interventional.
So we can, so the online viewers can't see that screen.
Okay.
So we want to post it up, and
Sure.
Jennifer's doing that.
So, and my office number is 650-934-7144.
Great, thank you.
Okay. We have the widest spectrum of procedures in the Western United States. There are a few comparable programs like Beth Israel Deaconess, Harvard Medical School, Cleveland Clinic, Duke, and UPenn. You all agree with that? There'll be a long drive for all of you, yeah? So that's basically it. So, okay, I'll be happy to answer questions. Yes, sir.
Before we, before we get to questions, again, I just want to make sure that everyone knows that we'll have this on our website so everyone can click in and download and print it, do all those kinds of things. And for our online viewers, we can take a couple of last questions. And then we have just about 5-10 minutes to go, and Andrea has some closing kind of.
Sorry, it took longer than.
No, we had a great active group. I'd like to say to everyone here, thank you so much. We had a great active night.
Before you close, I just want to commend you for what you do. When my mom was first diagnosed 8 years ago, this was not an option for her. And we can joke about it now, but her biopsy was done, her first biopsy was done in what we call a broom closet, because it was literally like this little room, and it was excruciating for her. And so I commend you for what you do and what you offer many patients, because it's incredible.
Okay.
Dr. Krishna?
Yes, sir.
Your 3D electromagnetic technology, what is the smallest size nodule that you can resolve to in terms of resolution, and how does that compare to a PET scan?
Great question. So, well, what can I do is different from what I need to do. So, as you know, size matters in terms of lung cancer. The likelihood of malignancy in a nodule that is less than 5 millimeters in diameter, maximum diameter, that is non-calcified is less than 1%. That percentage increases significantly when it crosses 8 millimeters. It goes up to 18%. And if it crosses 3 centimeters, it's more than 90%. So we don't need to biopsy all those small nodules. But the smallest nodule that I have successfully biopsied is about 5 to 6 millimeters. It ended up being a benign lesion. But I don't always biopsy those nodules. I was in there and I was biopsying something else, so I biopsied this nodule as well. But generally, nodules that are 7 or 8 millimeters or more, we target them, we biopsy them. It's not always successful, but if we get an answer, that's great. If we get an alternate diagnosis, that's even better. So, and PET scan, so PET scan is not reliable, period. But if you look at the literature, they say that in a PET scan that is, there are many reasons why a PET scan becomes unreliable. If the patient is very hyperglycemic, having a lot of glucose in their system, that is going to be a problem. If the patient has received insulin, it drives the glucose into the muscle, so that can become a problem. If the nodule size is less than a centimeter, and the literature varies in that. Some people say 7 millimeters, most people say a centimeter. If it is less than a centimeter, then PET scan becomes unreliable. If it is negative, it means nothing. But I have shown you examples of cases where there is more than a centimeter, but still PET negative, but positive for tumor, and vice versa as well. So PET scan has very limited use in diagnosis. PET scan has some utility in staging.
Thank you.
Sure.
Any other questions in our room? Neil.
When you talked about radioablation, so would that be the heating of it and then emulsifying it and then a removal?
No, so heating, promotes cell death, apoptosis. So that's basically how the cells die. So Emulsification is, using a surfactant reducing surface tension, so that doesn't apply to cell death per se. So if you put in either radiation, you actually cause necrosis, which is death, and apoptosis, which is programmed suicide of abnormal cells. And it also affects the normal cells, but if you do targeted application of these technologies, you could basically kill more tumor cells with less collateral damage.
Okay, so before we take the next question in our San Carlos office here at the living room, because we'll keep Dr. Krishna here after we lose our online viewers. We had just a couple of announcements we wanted to make sure our online viewers got before we, so we sort of went dark, one was that we had talked about in the beginning. We want to make sure that all of you got the latest edition tonight of our lung times, and we're very proud of the work that Sheila Vondriska is doing, our marketing communications. If you wouldn't mind, next time you happen to be at a physician's office or seeing your pulmonologist, would you leave some in their offices? It's a great resource. Anybody online, if they have any questions, just simply go to our website. It gets filtered to Danielle. She is the most amazing patient navigator, as all of you know. She's the one that directs and is now a national resource for other organizations as to how to do it. She should be your first phone call, so please take the newsletter with you tonight. I just wanted to mention that December 18th is our next lung cancer living room, and it's our theme is "What are you grateful for?" And I hope that everyone will be there. And then Andrea had a couple of announcements about Kelsey Harrison and her great lung run, and Chris Draft and a few other closing remarks.
No, and before everybody signs off, I did want to acknowledge the people that have signed in. Tonight we have people from, obviously, from the Bay Area, Northern California, Nebraska, New York, and Indiana. So we're just excited that we can offer this to them. And Dr. Ganesh, everybody online loved your presentation, and they thank you very much. You were great. So I want to let you know. So you guys may or may not know, I'm sure you know because it's all over the place. There's a young girl that has 99% accomplished running across the United States in support for lung cancer awareness. She is currently in Concord. And she is doing this, not only for her childhood best friend, but she's doing it for every lung cancer patient out there. And she is arriving in San Francisco on December 1st. This is just a meet and greet. This is just, her goal was to dip her toes in the Atlantic Ocean and dip them in the Pacific Ocean. So her dream is coming true. So she would like to invite any patients and their families up to greet her at Crissy Field in the city. And I have some little information on whereabouts at Crissy Field. But it's pretty cool. She's being escorted by the San Francisco Fire Department across the Golden Gate Bridge. She has about 120 people running with her across the bridge, and about 3.5 miles from across the bridge over into Crissy Field. So she has some great support. But again, she would love to invite all of you guys. So this is a personal invite from Kelsey. And then also make sure to tune into Channel 5 tomorrow night, because there will be a great long, a little news story about her tomorrow night. So, but again, from Danielle and Bonnie, thank you guys for coming. Danielle did log in, which was awesome and spectacular. And again, thank you, Dr. Krishna, for being here. And thank you, everybody online.
And I should say that we have a big shout out to Andrea and Jennifer. I'm not sure that Bonnie and Danielle have ever made cupcakes and frosted them personally for all of you. So before you leave, and sorry for folks online, if we could do sort of the three-dimensional and pass the cupcake to you, we would. But they're here tonight, so let's stay, enjoy some dessert, enjoy some more wine. Dr. Krishna has graciously said that he'd stay and answer additional questions. And again, we'll post all of the information online. So thanks to all of you for joining us. And Andrea had mentioned earlier in the night, Chris Draft, who is a former NFL player, has really...
So we met Chris a little bit a year ago, and he lost his wife to lung cancer last December. And the last team he played with were the Falcons. And him and his wife were married 1 year ago today. And they made it their quest to change the face of lung cancer. So in the month of November, he had a patient at every NFL football game. So I give him a huge round of applause for actually accomplishing that. And Dr. Krishna was at the game last Monday. No, 2 Mondays ago, the 18th. So when the Niners played the Bears. I'm a baseball person. But anyways, I give him a huge, he's doing great things. He's traveling the country and getting his message out, which is great.
He's one of our heroes, and as you know, it takes an entire village to raise awareness for anyone that will listen about this underfunded and underdiagnosed and undertreated disease. So we are doing anything we possibly can to ask people to run across America, do a Burgers and Bubbles fundraiser, join us at any one of our events, do some barrel racing, do anything that you possibly can to shout out about your experiences and about lung cancer, because we're here to fight it, here to beat lung cancer big time, as Jill Costello had always said. So we're closing out. For our online viewers, thank you again. Dr. Krishna, we said, the online viewers said you were awesome and you were great. So I have a feeling that tomorrow morning you'll need to go in a little bit earlier, because there'll be a whole bunch in your voicemail and in your email box for additional questions. So, all right, folks, have a great night, and let's stay and enjoy some cupcakes.